All right, let's do this. I look so weird on Zoom. I don't know if you think I look weird, but I think I look.
Different in person. It's always fun to see people.
I know, that's why I love this. All right, there are people joining us on Zoom, so let me get them in. Huh? I don't know if that screen will work, but I'm on a Zoom on mine, so I'm hoping. All right, can you guys hear me okay? Better in the outside, Alicia? Can you hear me?
Yes, I can hear you.
Okay, fabulous. We're gonna start. If you can't hear me, just let me know, okay?
Okay, thank you.
You're welcome. Can you see me too?
Yes.
All right, lucky you. All right. So first thing, placenta abruption. Placenta previa and abruption. This is in chapter 21. You probably have this in your notes, but critical to know risk factors and the assessment for placenta previa. It should say placenta previa and then right under abruption. See if you can find that.
Oh, it's for the third trimester.
Yeah, it's under the third trimester.
So the risk factors and
Risk factors, who gets this and what assessment? Now, as I mentioned before, previa.
Sorry, I'll take your bag.
I'm in the wrong bag.
Yeah, you're rummaging through there. Sorry.
So a placenta previa is a low-lying placenta. You don't know where your placenta is, neither does a placenta previa. It's going to be important to know this assessment on a previa. My baby looks great on the monitor. Perfect. My stomach is soft. Everything is looking all right, but with an abruption, abrupt, fast, you yanked off my placenta. That hurt me. Ow. That's how you remember an abruption. Why does that happen? Cocaine, blunt trauma, high blood pressure. One of the students in this cohort said the other day that her sister delivered and had an abruption. She said, it all came back to me from listening to the lecture. And then my sister had it. I knew exactly what was happening. So that was kind of cool, but with an abruption, you remember the girl that delivered in the field, high on cocaine? That farmer came in and told us what was happening. That is, what is her stomach gonna feel like? Rock hard. Rock hard because where the placenta got yanked off the uterine wall is filling with blood. So you palpate the uterus, rock hard. These women are usually going right for a C-section. All right.
So I guess that would be the difference between the previa and the
Yeah, the previous is going to have a soft tummy, the abruption, a hard tummy.
due to the blood flow.
That's right, into the uterus. Also, on the monitor, the baby on an abruption is going to look terrible because the placenta no longer is working, right? Placenta abruption, it got yanked off, so you'll see late decelerations. But on my placenta previa, everything is looking good. My baby looks good. I'm bleeding from below, but normally I'm looking okay. Any questions on those so far? Any questions about, anybody on Zoom have a question about
Do
the,
we need to worry about nursing interventions for these?
well, one nursing intervention is no vaginal exam on either one. So you are gonna, yeah, they do too, because you've got that low-lying placenta, so they have to deliver by C-section. And then you've got a, so both of those are C-sections, yes. Okay, anybody on Zoom have a question about an abruption or a previa? If you do, just unmute and let me know. All right, medications to know. Why do we do, if I'm talking loud, it's because I do that through Zoom. And then
You're not gonna-
and then one,
Your voice soft.
and then one time I came in and was doing a live session and I'm talking so loud and I'm like, wow. I'm like, sorry.
I'm visual, so you sound perfect.
Okay, good. All right. Medications to know, betamethasone. What do you use betamethasone for?
Developing the lungs.
That's right, mature fetal lung. They've got to have surfactant. If they don't have enough surfactant, that baby is gasping, retracting. It's a mess. Now, betamethasone is given to the mom. We don't need to know the dosage for the exam, but it's 12 milligrams. Deep IM for the mom, 24 hours apart times 2. You don't have to know that for this test. With uterine stimulant, if you think about the word stimulate, stimulant, we're going to make the uterus do something. So what are we going to make it do? Contract. And what is the medication we use for a contraction? Pitocin. You may also see oxytocin. So they're one and the same. Methotrexate. Methotrexate, you have a woman that's coming in complaining of pain on one abdomen or the other. This right side is killing me. I'm hurting. I'm bleeding. They check to see if it is ruptured. If it is not, we're going to give you methotrexate. Why? Because we want to dissolve the pregnancy. We want to make that pregnancy dissolve and go away and save your tube. Because if we don't give methotrexate, that baby will continue to grow and rupture the uterus or the fallopian tube. Yes,
Is that also used like in abortions?
they can use that in abortion. Yeah, but they have used it with abortions too. But methotrexate is to save the tube if we can. That is the purpose of it. Magnesium sulfate. This is a big one. Magnesium sulfate is important because one, a lot of people confuse this. Well, the main reason that I'm giving magnesium is because the mom's in preterm labor. Actually, you're only giving magnesium in preterm labor for neural protection for the baby. And it's only done for 24 hours. After that, we use it for preeclampsia. And that's the big one. We want to give her magnesium sulfate so she will not have a seizure. You have a seizure, and that's going to be a problem. So, mom's on magnesium. And how do you know she becomes mag toxic? How do you know she's gotten too much? No deep tendon reflexes. Decreased respirations, 12 and under. She might show signs of pulmonary edema. That would not be good either. So we want to keep track of this mom. If she becomes magnesium toxic, what am I going to give her to help her out? Calcium glutamate. That is correct. Now don't forget with methotrexate also, you have to tell mom you cannot drink alcohol after I give this. You cannot take folic acid. It acts like an antagonist and will make you super sick from that medication. So we want, I know that's for methotrexate. Yeah,
No.
with methotrexate, no alcohol, no folic acid.
I have a question, sorry to go back, Joyce.
Oh, you're good.
But right here for the ectopic pregnancy, it says, it made it sound, maybe I read this wrong, but it made it sound that this occurs because there's an obstruction or the adhesion of the fallopian tubes from a previous infection.
Right.
So is that, so there is a cause to why the ectopic pregnancy?
Yeah, it can, right. It can happen because you remember that cilia that moves the egg down? Now, if you have pelvic inflammatory disease, some of those cilia are gonna disappear, which leaves a hole that egg can sit in and not get moved down. And that will cause an ectopic pregnancy, because it grows in the tube.
Can the cause sometimes be unknown?
It could, also if she has a IUD, those two at the top of the T, it's holding the egg in the fallopian tube and it won't come out. But it could be for no reason at all. Although sometimes you've had tubal surgery before, that kind of thing. But usually there is a reason that it does
And then
happen.
just do the scar tissue.
And that would be scar tissue in the fallopian tube
Slow
that's
it
not,
down.
yeah, that won't let it go. They say,
Ever move the fetus to uterus?
and no, I can't. It's already attached right in that tube. That's the sad part. We wish, maybe someday we will, I doubt it, but, or if we could take that little fetus in the bag and attach it somehow with the uterus, that would be so great, but not likely, not likely. Good question. All right, ROGAM. Oh, one thing about magnesium sulfate that I mentioned before. Mom's got preeclampsia. We're giving magnesium sulfate to prevent a seizure. Now she has the baby. Doctor said, well, let's start her on Pitocin because we want that uterus to get firm and tight and not bleed. But she's got magnesium going, which is a smooth muscle relaxant, right? Now you got Pitocin and magnesium doing opposite things, likely gonna have a postpartum hemorrhage. Is that what you did? Were you on magnesium? Yeah, yeah. It's very common. Very common because Pitocin and magnesium are fighting each other. ROGAM. Now, ROGAM is a medication that we're protecting the next pregnancy. If we have an Rh negative mother at 28 weeks, because you can't do a direct Coombs test on a baby in utero. So what we're going to do is an indirect on mom. Indirect Coombs test on mom to see what her titers are. But likely we're going to give her ROGAM if she's Rh negative. Then when she has her baby, if the baby is still Rh negative, then we're going to give her no ROGAM. If the baby's Rh positive, we are going to give her ROGAM. Does that make sense? So if mommy's negative and has an Rh positive baby, ROGAM within 72 hours. If she is Rh negative and has an Rh negative baby, mommy does not need ROGAM. But let me tell you, there's situations that a mom can have where you have maternal and fetal blood that mix. With an Rh negative mother, she's got to have ROGAM to protect the next pregnancy. So what are three types of situations that can happen where you have fetal and blood mixing? Amniocentesis, a miscarriage, ectopic pregnancy. Those can all be early on, but she's still going to need ROGAM to protect another
So
pregnancy.
they're doing amniocentesis before 28 weeks.
They can, yeah,
So if
especially,
they were to go in to do that.
Yeah, then they give her
just
ROGAM.
ROGAM.
Yeah.
Without doing the titers.
right, because if she's Rh negative, that would be a risk. Yeah. Then Tributaline is the last drug that I need you to know about. Tributaline is probably under your preterm labor part from last week. Yeah. Tributaline is a medication that we give to make labor stop right now. You come in preterm labor, we're going to give you 0.25 milligrams sub-Q Tributaline, and it will stop your contractions right now. Now, before I give it, Mom, do you have any history of cardiac problems? Because we're going to make your heart race. We're going to cause you to have tachycardia. You're also going to have your respirations increase because you're going to feel so anxious. My heart. It's going to make you feel anxious. Mom, are you a gestational diabetic? Do you have any diabetes? Because this medication is going to increase your blood sugars to make you hyperglycemic. Then, mom, do you have any history of hypertension? Because this can also have a reverse where you could be hypo. So we got to ask her these questions before we give it, because within 5 minutes, her heart is going to race like nothing. It's going to go so fast. She's going to be anxious and feel like she's going to die. Just means the medication is working well. Yeah.
Is there a blood pressure that you'd want to stay under before you administer that?
No, they don't usually give parameters for it with
Just if you're-
terbutaline.
yeah, hypertension. No.
Yeah, well, they'll see how high it is. They're kind of gonna weigh it out, and then the doctor will say, yeah, give it or don't.
Is it 20 points?
Yeah, it doesn't really matter. It's kind of like a doctor thing,
Mhm.
but I've never seen them hold terbutaline because of a blood pressure. They feel the benefit outweighs the risk. So they will just say, yeah, let's just give it and it'll be better. Because we don't want her to have contractions. When else would you give terbutaline? Doing an external cephalic version. You're trying to turn that baby. We're manipulating the uterus. We're going to make it contract. We don't want that. So that's another time you would give terbutaline. All right. We talked about placental problems. A likely question would be if you have, and that was from today's or this week's lecture in chapter 23. There should be pictures in the back of your outline that's talking about in chapter 23. You're in 21, Andrew.
24.
Okay.
There we go.
There you go. All right. In the back, it shows different placentas that are shown, hopefully. That's placenta accreta. But if you look on the PowerPoint, I have pictures of the different ones. Actually, you just need to know the first two. Oh, there you go. There. All right. Yeah. So one has 2 lobes and the other one is just circling. The maternal is coming over on the, you probably may not have it. It's probably on the PowerPoint.
Is that it?
Yeah,
Okay.
good job. So I'm just going to give you a description of a placenta. It's going to be pretty to the point. I don't think you'll miss it, but it's just giving you an idea. You have a baby that has a cord around the neck. What is that called? And you have a picture of that on the, right there. Nuchal cord. It's a nuchal cord around the neck, and we count it every time they take it off the baby. It's a nuchal cord times 2, nuchal cord times 3. If you have a cord that has 1 artery and 1 vein, that's not a problem for the mother. The problem for the baby would be that we're going to do a cardiac workup and a kidney workup to see if there's any anomalies there. All right, prolapse cord. Prolapse cord was in the lecture for this week, chapter 23. It's at the very beginning of your outline, talking about a cord prolapse. So we're not going to break her water if we don't see that the baby has come down. Because if the baby is still too high, we have a risk for a cord prolapse. Or if the baby is breached, we have a risk for a cord prolapse. A lot of people say, why a breach? Well, think about the rear end. Kind of goes up into the crack and down. Well, the crack part is where it can hold fluid, and that fluid can come down and have a cord prolapse. What are we going to do for a cord prolapse? Now, if you help it to remember, it's chest, knee. Chest on the floor, knees up. It's called a knee chest, but however you can remember it.
Can you show?
I know. Let me show you a picture. Yeah, seriously, I can't even tell you how many times I've been on the floor there. Yeah. Uh-huh. And then, okay, we're gonna do a knee chest, oxygen. We are also going to call for help and apply pressure to push that baby off of the cord is what the point of that is. Pretty much that is what I'd like you to concentrate on is what are you gonna do about it, which is right there, and who's at risk for it. All right, a molar pregnancy. Molar pregnancy, that was under the second trimester last week in 21. We talked about that, chapter 21. And it's in the second trimester. It's also gestational trophoblast. So you'll see either one. Do you see it, Andrew?
I'm in the second.
Should be pretty much after a topic,
Okay, right after.
not far.
Topic's on the third one.
No.
It's- There you go.
First, and then
Second trimester.
Okay,
And then it should say trophoblastic
yeah.
or a molar pregnancy. So the big thing with this is to know what is the risk factors, low keratin, low animal fat. It is diagnosed by ultrasound. And what do we do about it? A DNC. There is a sentence down there that says she is at risk for choriocarcinoma. And that's the big things I want you to know, except one more. Size not equal to dates. Size is greater than the expected date. So if she's 12 weeks, but you're massaging a fundus that is 16, you're going to rule out an ectopic pregnancy. I mean, a molar pregnancy. Do you see where I'm at?
No.
Okay. You find trophoblastic?
Right.
Okay, then she's at risk for choriocarcinoma, we have that. It is diagnosed by ultrasound. Okay, and then, yeah, you got that. Yeah, you got it.
But then size, I was caught up on size.
Oh, yeah, it does say size greater than date somewhere in here.
Almost right.
Yeah, it'll be on there. I was telling the students to highlight that. So size greater than date.
so if the baby's measuring big.
And there is no baby. What's growing in there are those little vesicles that are full, it's like a snowstorm pattern. So if we did an ultrasound, there is no fetus. The placenta that would have started with a pregnancy got infected and no baby developed at all. But now you've got a snowstorm look on an ultrasound. These little vesicles are full of prune colored fluid. So if those broke, you'd see purple coming out of the vagina. You may remember the video that we saw on that, but that's what was coming out.
Why women who are taking cold are at risk for this?
Because it could be that the baby never develops, but the trophoblast or the placenta will start to develop. It's just a proliferation. It's not uncommon. Yeah, do you have a picture of it? Yeah, but that's okay. Yeah, that's it. That's it. Good. Miscarriages. Now, miscarriages, we need to know. You had infertility issues though, right?
I went to my babies.
Yeah.
My right tube was gone, lasted.
Right.
I don't obviously. All of this is what-
You just want to be unusual, that's
I
all.
just want to be comfortable.
That's it. That's it. All right, miscarriages. You have a miscarriage. That is in chapter 21, under the first trimester. Should be at the beginning. Right at the beginning of that, and it talks about the types. If it's threatened, the good news is, Mom, you're not dilating. No product of conception came out. You're bleeding, but it's threatened. It's possible, but it's looking good so far. A complete is just that. Everything came out. Everything came out. Baby, water, placenta. Incomplete, something came out, but not everything. Incomplete, I had an incomplete miscarriage. It wasn't missed, it wasn't complete. Incomplete means probably the baby came out, not placenta. Don't get too hung up on those words. You will be able to see a definition and then just tell me what kind of miscarriage it is. And you should be fine. It's pretty self-explanatory. Preeclampsia. Preeclampsia is toward the last part of chapter 21. It's in the third trimester. You have preeclampsia. Do you remember the triad to say that she's hypertensive? If she's hypertensive, there is a triad here. Okay, yeah, gestational hypertension, and the triad was,
Hypertension.
yeah, hypertension, edema, proteinuria. Good.
But my sister just barely went for her 30, I think we're at 38, we're 38, 37, 38 weeks right there. And she just barely, her blood pressure was a little high, her feet were starting to swell.
Swell.
And I was like, I wanted to do a Colone's test. I haven't got to see her yet.
Oh, right.
Well, are they worried about you? She's like, well, she's a little worried that my feet were swelling. I was like,
Yeah.
I say, because your blood pressure
Oh,
went up.
right, that's right.
So,
You know, another thing, I'm glad you brought that up, because a lot of women go in and have their blood pressure done, and they'll say, oh, your blood pressure's high. Did you just walk her in the room? Did you let her sit for a few minutes? You know what I
I wish
mean?
they would have taken it again.
Yes,
I wish they
and
would
that's
have
what they're
done
supposed to
it.
do.
It's only a nurse, the doctor wasn't there.
But even the nurse should know that. Okay, the first one is elevated. Well, I'm gonna do another one and see if that's still high.
Yeah.
Because we just walked her in a room. She's nervous. She sits down. It's a white coat syndrome. What are they gonna do? Is everything all right? You know what I mean?
You know what I think was funny is that they don't do urine, at least in California, they don't do those routine urine exams every time you go in.
To the office?
I never got
With
my
my
whole
first
pregnancy
one,
last time.
Yeah.
They did, but with my second one, they never did, which I also thought it was funny, because I'm like, don't you see my chart?
Right.
that I had to come? So with my
Yeah.
Right,
first,
right.
you would think that you would.
The hospitals that I worked at, or when I was practicing as a midwife, I had every nurse do that on a patient that came in. Because you're looking for those three things. You're looking for protein, glucose, ketones. You know, you got to know those. And if you don't, you're going to miss it.
And ask her to do
Yeah, that'd be good. Because they don't need to do a sample, just dip it right there and look at the stick and see what it is.
So what was that triage that you said it had?
The what?
Hypertension.
Oh, the triad, hypertension, edema, proteinuria. Now, a variant to gestational hypertension is what? Do you remember what that is? A variant to gestational hypertension is HELP syndrome. HELP stands for hemolysis, elevated liver, low platelet. Now, you can't look at her and say, hey, you've got high blood pressure. Or if you do it, you'd say, yeah, your pressure is high, but that would not tell you, do you have HELP syndrome? How do you know if she's anemic if you don't do lab work? How do you know she's got elevated liver enzymes if you don't do lab or low platelets? So I'm probably going to ask a scenario that ends with the client has low platelets. What does she have? HELP syndrome would be the low platelets, and that's anything under 100,000. So diabetes, you got to kind of know And that should be right in there after, let's see, that was in chapter 21. I can't remember exactly where that was. More in the front, I think.
I think it's in chapter 20.
Oh, yeah, it is chapter 20. It is, sorry. Chapter 20 is cardiac diabetes UTI. What do I need you to know about diabetes? What is hyper and hypoglycemia symptoms? Now your ATI does have that pretty well spelled out. ATI does not have cardiac in it. So if you can know what hyper and hypoglycemic symptoms look like. What does diabetes do to the mother? Well, she could have a C-section because of a macroscopic baby. She might have more lacerations delivering vaginally. But what does it do to the baby? The baby could be a shoulder dystocia. And for sure, this baby is going to have hypoglycemia. That baby is getting all the glucose from the mom, no insulin. So the babies get bigger and bigger and bigger, causes a problem with hypoglycemia. One more thing about diabetes, A1C. On your outline under diabetes, it should talk to you about hemoglobin A1C. Does it mention that?
I saw it.
Yeah, there's 4 things that I need you to know on that. A1C. Do you see it, Andrew?
I'm scanning it real quick. I'm not seeing it out of
Okay.
That measures 90 days of blood sugar.
Yeah, there you go. So this is what I want you to know is the level we want to be 6% or less. It is a blood test. A lot of students say, well, they dipped her urine and it had glucose in it. That's just telling us that she's likely going to get an infection from all the sugar on there. That's not a blood sugar test. So it's a blood test. We want the level to be 6% or less. We want it to be done at 28 weeks, no other weeks, 28 weeks. And there was a 4th thing. 20
every 3 months.
every 3 months. That's it. Every 3 months. Yep. Good. With cardiac, also in chapter 20, what is the best position to put a mom in that has cardiac disease? Head of the bed elevated and on her left side. That would be the ideal position for mom to be in. What is her baby going to look like though? With a cardiac mom? Small for gestational age. It's going to have a low birth weight because that placenta has not been functioning well for baby. Mom can't even get her own heart together with cardiac. So you may see late decelerations on this baby. All right, good. Any questions so far? You doing okay? All right. If the baby is OP, so the baby is back of the head, the occipital bone is facing mom's posterior, what kind of labor is she going to have?
Painful.
Painful back labor, back labor. Every time she contracts, it pushes the head on her spine. Oh, my back, my back. And then what we do, sacral counter pressure. Every time she has a contraction, we're going to push on that sacral area and relieve that pain. But let's say we tell the mom, let's see if we can get the baby to turn into an OA position. How would we do that? Do you remember that? We kind of talked about that this week. It was in chapter 23 when we talked about the position of the baby. It's painful. We give sacral counter pressure and we're going to put the mom on her hands and knees. Hands and knees. And that should have been in chapter 24 where it talks about the positions of the baby. I mean, 23, are you at 23?
Yes.
Okay. Right, and then if you turn the page, it should say in the middle paragraph, right in here, here it is. If the baby is OP, put mom on her hands and knees, let her abdomen hang down and see if it'll turn. All right. Moving forward, on the topic pregnancy. We just mentioned this not long ago. What is it caused by? PID. Remember, you're not going to have enough cilia moving that egg. It could also be IUD. The IUD is holding that egg up there. So that is going to be a problem. Okay, uterine inversion. This is where you pull the uterus inside out. And that was also, I think it's under number 7 or 8 on your outline for chapter 23. Should say uterine inversion. That is too much traction on the cord. That's all I really care that you know about it. You pull the uterus inside out by putting too much traction on the cord, and you're going to turn the uterus inside out with the placenta still attached. Not a pretty sight. Not pretty. DIC. Also, I believe in your chapter 23 for this week. It should have a paragraph about DIC. I think going the other way, yeah. And it's, I think it's 23. And there should be 2 little graphs. Right, keep going. There should be 2 graphs. Not that.
Like that graph?
That's the bishop score. There, right there. There it is.
20, I believe.
Is that,
I believe it's in 20.
it should be in maybe 21, not 20. Or it even could
It
be
is 21.
21 in
Last page
chapter
is 21.
last. Okay, good. DIC.
Not
Okay. All right. There's a problem with clotting blood. So with DIC, when can this happen? You remember that story, the little fetus stuck up in there? That can cause you to have DIC. A mom comes in, I don't feel good. Do you have a headache? Yes. Do you have blurred vision? Yes. You could have a cerebral hemorrhage. A mom can have a cerebral hemorrhage. So with this particular test, you're going to be asked stuff like, how does this affect mom? How does this affect baby? DIC can affect a mother if she has a miscarriage, that little fetus bleeding up in there, or preeclampsia, which could be a cerebral hemorrhage. We're doing okay so far? All right. Who can be induced? How do we decide if somebody can be induced? We're going to do yeah, preeclampsia can be induced. Active herpes, no.
That's true.
Bad strep, no.
And face.
And a face presentation, no. How do we know that she has got a ripe cervix? A Bishop score. And that was that picture where we are looking, where is the cervix? Where is the baby station? That's what we're looking for. If we're going to induce someone, we want to see a Bishop score of 8 or better when we add up all of those percentages or those numbers. All right. What about precipitous labor? Precipitous labor. If I were to ask you a question that said, the mom's been diagnosed with precipitous labor, what does that mean? And what is the risk to the mom or the baby? And that was in 23 this week. That was this week. They dilate really fast in 3 hours or less. Yes. The risk to the baby is possible subdural hemorrhage.
And lacerations for mom.
And lacerations for mom, yes. That is precipitous labor. The three things I want you to know is it's fast, under 3 hours. Do you see it in?
Yeah.
And then baby can have a subdural hemorrhage. Mom has more lacerations. And then the last thing, premature cervical dilation. This is great to show you in a class, not so much on Zoom. So let me come over here. I'll come over here so you guys can still see this.
Do you know which chapter that was?
Yeah, that was in 21, premature cervical dilation in the second trimester.
No, they suture it up.
Yep, they do. Yeah, so this is not, don't confuse this with recurrent miscarriages. That happens in the first trimester. Premature cervical dilation is when your cervix dilates. She feels a ton of pressure. So here's the cervical os right here. They're going to take sutures and go back and forth like this across it until they make a purse looking thing. They're going to make like a tight so that she won't dilate. Can she still break her water? Yes, but she won't dilate. If she breaks her water, they got to cut it out. What do I need you to remember about that? This is a McDonald's cerclage. I need you to know that they put that in at 12 to 14 weeks and they take it out at 37 weeks.
But if the water breaks and
And then they'll just take it out.
14 minutes.
Yeah, then you're done. You're done. Once the water breaks, they undo that. It's done in the main OR or in the labor and delivery OR. But when they take it out, you're just in the office and no big deal. They just put a speculum in and take it out. All right, any questions for me on Zoom?
So if the water breaks and they take the baby, or they just take the suture out?
They just take the sutures out because she'll dilate. She will dilate. This is a fairly common practice that is not rare to see this done. When I was working in the hospitals, I saw this maybe once or twice a week done. So it's fairly common. All righty, people, any other questions for me? Anybody on Zoom with a question? Y'all good? In the hood? That's what happens when you work in South Central Los Angeles.
These right here, I love you on Zoom because you would hear me cracking up. all
Oh,
the
no,
time.
yeah, it's okay.
All the time.
Everybody.
Yeah. EAB is elective. I went in and I didn't want the baby anymore, so I had an elective miscarriage. That's in chapter 21 in the very first part where it's talked about the miscarriages. There's 3 letters there, EAB, and then TAB is therapeutic. Mom, to save your life, we need to get rid of this pregnancy. That's what that cardiac doctor said to several of the patients. You won't survive if we don't do a therapeutic abortion. And then SAB, spontaneous. It just came out by itself. Can you think of anything else? Now, as you go through these 4 chapters, a lot of times when I was lecturing, I would say, highlight this, highlight that. We may not have gone over it today, but it will be important to know. So anything that I said, highlight this or underline that, you'll want to study those as well. For those of you on Zoom, in case you forgot, the test opens tonight, 1 minute after midnight, closes next Thursday.
Thank you so much.
You're welcome. You guys take care. I think that's it, unless you have a question. I'll end the Zoom call.
Thank you. Have a good day.
You too. Bye-bye. So cute.